In this lecture, we will cover Chapter 32, Myeloproliferative Neoplasms. So the myeloproliferative neoplasms are clonal hemopoietic disorders. So when we talk about it being clonal, it's basically going to reproduce that same mutation every time it divides or makes a new copy from that stem cell. And so they are genetic mutations in the hemopoietic stem cells that will actually result in an expansion, excessive production, and accumulation of mature erythrocytes, granulocytes, and platelets. So it's just going to put out too many of those cells into production. So you're going to get a lot of those cells. You're going to have those high counts in all of these cells. And so it is characterized by the clonal expansion of one or more myeloid cell lines, but it's usually going to be just one of those cell lines that will actually dominate. And so that cell line is going to continue to have that genetic mutation. So once you actually have that mutation that's in place, then you will have the propensity to actually transform into other myeloproliferative neoplasms, or they could actually progress on to an acute leukemia. Now, the myeloproliferation is largely due to hypersensitivity or independence of normal cytokine regulation that is actually resulting from some sort of genetic mutation that will reduce the cytokine levels through that negative feedback system that is normally induced by mature cells. So basically that response of whether or not it needs to destroy itself or whatnot. Now there is evidence that actually suggests that the hemopoietic stem cells and the hemopoietic progenitor cells in the myeloproliferative neoplasms is partially controlled by their interaction with the bone marrow stroma and the bone marrow microenvironment. So this will include things like the adhesion molecules, the cytokine receptors, and the soluble and membrane-bound factor receptors. So cellular expansion occurs in varying combinations within the bone marrow, the peripheral blood, and the tissue. So with your myeloproliferative neoplasms, they are predominantly chronic, but they have 3 phases. They can have 3 phases: accelerated, subacute, or an acute phase. In certain patients, it's very difficult to be able to make a clear delineation between your subacute and your chronic phase, just using your clinical and your morphological findings. So originally, back in 1951, the myeloproliferative neoplasms have the pathogenic similarities as well as common clinical and laboratory features that resulted in the various classifications. Now, we have kind of since expanded for that, and WHO has kind of further delineated these classifications. So WHO defines, and this is the World Health Organization, they define the classifications into chronic myeloid leukemias, polycythemia vera, essential thrombocythemia, and primary myelofibrosis. Now, the primary myelofibrosis, it can be further delineated into 2 stages, the pre-fibrotic stage as well as the overt fibrotic stage. And then there are also a couple other less common myeloproliferative neoplasms to include chronic neutrophilic leukemia, chronic eosinophilic leukemia that's not otherwise specified, and then your myeloproliferative neoplasms that are unclassified. Now your textbook does have this great chart that kind of shows you how they're kind of further broken down into that WHO classification based off of the various diagnostic criteria. So let's kind of first just talk about what all of these kind of have in common, or what sets one apart from the other. So first we kind of need to understand that the essential thrombocythemia, the polycythemia vera, and the primary myelofibrosis are all genetically related. In most cases, they do all have the presence of the JAK2 mutation. And in all cases, there is no mutation within that Philadelphia chromosome or that BCR ABL1 fusion gene. And just to kind of remind you what that is, with that Philadelphia chromosome, there's an abnormality in chromosome 22, and then there can be that fusion gene, the BCR ABL1, can take place in between the 9th and the 22nd chromosome. So it's got more to do with the location in the chromosome, but just be familiar that in all cases that abnormality is not present, so that's not what's causing these issues. So each presents with a proliferation of one of the primary myeloid elements. So when we look at essential thrombocythemia, you're going to have thrombocytosis. Polycythemia vera, you're going to have your erythrocytosis, and then within your primary myelofibrosis, then you will actually start having a left shift, and you're going to see those the neutrophil line that will be actually affected. Now, in essential thrombocythemia and polycythemia vera, they're very closely related because they actually share several driver mutations, whereas with your primary myelofibrosis, it's actually a combination of overproduction of hemopoietic cells and stimulation of fibroblast production, which can actually lead to ineffective hematopoiesis. And then, of course, it's going to you're going to also have peripheral blood cytopenias. Now, with your chronic myeloid leukemia, you will have neutrophilia with a shift to the left. So this is going to include all stages of your myeloid development. So you're going to see a presence of some of those early cells. And then you also, what's going to differentiate this from the others is that you will actually have the presence of that Philadelphia chromosome translocation and or that fusion gene is actually going to be present within that, in between that 22nd and 9th chromosome position. Now, just so you're aware, some of the WHO classifications for the myeloproliferative neoplasm diagnosis will actually include, for your CML, it does require that Philadelphia chromosome and or that BCR ABL1 fusion gene to be present. There has to be a minimum bone marrow blast count threshold to be able to differentiate your myeloproliferative neoplasms from your acute leukemias. And so that's been reduced from 30% to 20%. And then they've also established that eosinophilic disorders have actually been reclassified. And then atypical CML, the Philadelphia chromosome and that BCR ABL1 negative cases with myelodysplastic and myeloproliferative features. So they've kind of further classified some of these things based off of some various criteria. I'm not expecting you to know exactly what these different changes have happened over the years. Just be familiar that they're constantly redoing that classification system. So every few years you can see some variations and change of how a disorder is classified as we kind of expand upon testing and we're better able to see and differentiate some of these disorders. So your myeloproliferative neoplasms can present as stable chronic disorders that may transform first to some sort of subacute phase and then onto an aggressive cellular growth phase. They can manifest as a depleted cellular phase, such as like a bone marrow hypoplasia, or they can actually exhibit clinical symptoms and morphological patterns that are characteristics of subacute diseases that will actually be followed by a more aggressive cellular expansion. You can also note that the familiar myeloproliferative neoplasms have been described in families in which you have actually 2 or more family members that are affected by it. So there can be some sort of genetic inheritance to that abnormal pattern. So now let's first discuss chronic myelogenous leukemia, or also referred to as chronic myeloid leukemia. So CML is a myeloproliferative neoplasm that happens because there's a single genetic translocation in a pluripotential hemopoietic stem cell that is actually producing an abnormal overproduction within a myeloid stem cell line. And so you'll have a predominance of immature cells that are going to be from that neutrophilic line. So all of those abnormal cells are going to result from that neutrophil line. So CML actually will start off in a chronic clinical phase, and then if it's left untreated, undiagnosed, it will actually progress to an accelerated phase about 3 to 4 years later, and then it will often actually terminate in an acute leukemia during a blast crisis. Now that progression to acute leukemia can either be a myeloid lineage or it can be a lymphoid lineage. Now patients will often have symptoms like fatigue, decreased tolerance to exertion, anorexic, as well as a list of other things that can be suggestive that there's something going on, including weight loss, spleen enlargement. They may have frequent infections, anemia, bleeding, again, that enlarged spleen, and all of this is secondary to that massive pathological accumulation of those myeloid progenitor cells that could be present either in the bone marrow, the peripheral blood, or throughout the body, throughout the tissues in the body. Now, they will also present with neutrophilia, and then they will have multiple stages of the various cell lines can be present. So any of those granulocytic lines can be affected, and you can also have an increase in platelet that you actually see being present in that CBC or on that blood smear. Now, CML can actually be diagnosed in any age, but it's predominantly seen in those that are somewhere between 46 to 53 years of age. It is more common in men than women, and it has a mortality rate of about 1.5 per 100,000 individuals that are diagnosed. And of course, this statistic is before some of the better treatment options have been developed, so those numbers have been reduced a little bit over the years. And of course, diagnosis is based off of those mutations, either through the Philadelphia chromosome or that BCR ABL L gene. So diagnosis is made either from a cytogenetic or a molecular standpoint. So cytogenetic, we're looking for that Philadelphia chromosome mutation. And for the molecular level, we're doing the molecular testing to look for that translocation between that 9th and 22nd chromosome. Now with that Philadelphia chromosome, it's still kind of not really understood how that happens or how that mutation takes place, but it does appear to be more often in populations that have been exposed to some sort of ionizing radiation. In most patients, there's not really a cause that can ever be identified. There has been some studies that have kind of found that there may be some kind of correlation between being transfused with cells, donor cells that have actually that also has that abnormality. So maybe that patient doesn't necessarily have that disease progression, but they do have that mutation. There has been some links there that are thought to be a possible way that patients can develop that mutation. But again, that Philadelphia chromosome, even though it's not widely understood, it does seem to be, you can actually see this alteration in other neoplasm. So while it may not be directly related to just CML, it does help with the diagnosis of it. Additionally, I kind of want to point out that the pathogenetic mechanism is very complex. Your textbook does kind of it kind of walks you through some of the different mutations that happens and where it happens and what it results in. But basically, it's just disrupting that normal cell function where the cell has the various chemicals that kind of alerts it, hey, it's time for my programmed cell death so that my cell can be recycled or whatnot. And so there's some sort of disconnect in that normal cell function. So you don't have that programmed cell death like you're supposed to have with anything that's aging. So you get that abnormal result where you have too much of those cells. For diagnosis of CML, patients do have a dramatic morphological change within their peripheral blood and their bone marrow that is going to demonstrate that there's an expansion of the granulocytic pool. Within the peripheral blood, you will see a left shift, and that can extend all the way up through the promyelocytic stage, and also you can have some occasional blasts. The lymphs and the monos, they will have an absolute count that's increased, but their relative count will be decreased, and this is just going to be based off of the fact that you have so many cells present that once you break them down in comparison, then you're going to see that those lymphs and monos are not affected because it's primarily just going to affect that granulocytic line. Now your platelets can be normal or increased, and you can occasionally have some abnormal morphological appearance to them. It's rare to see a nucleated red blood cell, but they may be present. Within the bone marrow, it's going to be hypercellular, and this again is going to be due to that increase in that granulocytic production. You can have extramedullary granuloparesis, which can be, you can see that within the spleen and the sinusoids. Other laboratory findings could include an increase in that urea to cause things like gout, urinary uric acid stones, uric acid nephropathy. And then another thing that I'd like to note is that traditionally CML was diagnosed, or diagnosis was aided by the use of an LAP stain. And what that is LAP, or leukocyte alkaline phosphatase, is actually an enzyme that is present within the membranes of your secondary granules of your neutrophils. So you're basically looking for the presence of those. And what an LAP stain does is actually will kind of traditionally help to differentiate CML from any sort of leukemoid reaction that's caused by infection. Now, with an LAP stain, it is decreased in untreated CML patients, and it can be normal or increased in a leukemoid reaction. So looking for that variation helps us to kind of determine, or at least it did, when it was really the only test that was kind of present at the time. It kind of helped with differentiating some of these disorders. So prognosis for CML is going to be dependent on a variety of things, including at what stage diagnosis is made, treatment that is involved, the various treatment options, and how the patient will individually respond to those treatment options. So what works for one patient may not work for the other. And here there's a list of various treatment options that are available out there now. I'm not expecting you to know all of these. Your main focus is just going to be on being able to detect the presence of abnormal cells or the overproduction of cells, and then just kind of further being able to differentiate, is this something that is an actual leukemia? Does it need to be presented to the pathologist? And of course, pathologists will kind of guide the physician from there. So your main goal is just to recognize when abnormalities are present, and how are you going to differentiate that from something else. Polycythemia vera is a neoplastic clonal myeloproliferative neoplasm that commonly manifests with a pan-myelosis in the bone marrow with an increase in the erythrocytes, granulocytes, and platelets within the peripheral blood. Now, incidences within the U.S. are about 8 to 10 cases per million. It's rarely seen in children, but it's most often seen in individuals that are 40 to 60 years of age with a peak incident after age 60. We see it more often in men than women and more commonly in whites than the black population, where it's actually more common with those of Jewish descent. A familiar disposition for polycythemia vera may exist. So in other words, we do see it tend to be in more in some family lines versus other family lines. So it does kind of lead you to believe that there is some sort of genetic disposition or inheritance to it. Now, diagnosis is based off of major and minor criteria. Within your major criteria, you're looking for predominantly a hemoglobin that's greater than 16.5 in men and 16.0 in women, or a hematocrit that's greater than 49% in men, 48% in women, or you can also see an increase of the red blood cell mass mean that's greater than 25% of the normal mean of normal populations. Within the bone marrow, you do see that panmyelosis, which is going to basically be hypercellularity for the particular age of that patient, and you're going to see it in the different lineages, including the erythroid, granulocytic, and megakaryocytic, or your platelet lineage. With you can have actual pleomorphic mature megakaryocytes, so you can have it's a differentiation in the size of those cells. And you also are looking for the presence of that JAK2 mutation, and there are a couple of different ones that can be present. So looking for that JAK2 mutation is going to be critical in this diagnosis. The minor criteria will be subnormal serum EPO. So because that is affected, that red blood cell lineage is affected, then you're going to see that EPO affected as well. Now within the laboratory, the patient's peripheral blood is going to appear normal. So you will have normal cytic, normal chromic red blood cells, mature granulocytes, normal sized granulated platelets. The bone marrow, however, will have normal blasts that can actually collect in large clusters, megakaryocytes that are large, and they have a lobulated type nucleoli, and the bone marrow sinuses are enlarged without fibrosis. You can have a pseudogaucher cell, may rarely be present. About 80% of patients will manifest with bone marrow the bone marrow panmyelosis, and 100% of bone marrow volume may actually exhibit the hematopoietic cellularity. So the other 20% of those patients will exhibit a lesser degree of cellularity in the bone marrow and the peripheral blood. Now, if this disease is suspected based off of your clinical presentation of the patient, then of course diagnosis is going to be made based off of the previous criteria that was listed by WHO, and of course doing that genetic testing is also going to aid in that diagnosis. Now, the clinical presentation for polycythemia vera will often present with a history of mild symptoms that will happen over several years. Although some patients, you may actually have a diagnosis that will be sporadic, just based off of the laboratory values that are found in the patient that's asymptomatic. Initially, it's going to manifest in a proliferative phase, which is basically going to demonstrate an increased red blood cell mass. Because of that increased red cell mass, then you're actually going to have blood that is hyperviscosity. So because it's a little bit thicker than what you would typically see in patients, then it can actually lead to other problems, such as cardiovascular disease. Now that hyperviscosity and hyperproliferation of those cells can present some symptoms that include things like headache, weakness, weight loss, fatigue, pruritus, which has been associated with the elevated blood histamine, and is often not associated with a rash. So you can have those increased histamine, but not necessarily a rash that will demonstrate any sort of cause for it. About half of these patients will have some sort of thrombocytosis, and about 1/3 of them will actually experience some sort of thrombotic or hemorrhagic type episode. And of course, this is going to increase with age, especially with patients that are like 60 and above, and that are either patients that have a history of some sort of thrombosis. They're considered high risk for any sort of thrombotic or hemorrhagic event. And of course, there are risk factors that can kind of increase their risk. This will be things like uncontrolled hypertension, diabetes, smoking, obesity, increase in cholesterol. So any of this can actually lead to some sort of thrombosis-related event like a myocardial infarction, any sort of cerebral ischemia or stroke type episodes. So naturally, if they're having that thrombocytosis, then it's going to put them at an increased risk for other things and other complications. Now, the stable phase of polycythemia vera, it can actually progress. So once they're stable, it can actually progress to a spent phase. In a few patients, that usually can happen within about 10 years of diagnosis. Now, in that spent phase, patients will start to experience some progressive symptoms like splenomegaly, or that enlarged spleen where you actually have some bone marrow hypoplasia and peripheral blood cytopenias, and you can also present with pancytopenia. And of course, they can have other things that can present as well. The more that disease kind of progresses, the bone marrow can start to demonstrate a fibrosis, so it reaches a point where it's not able to produce much cells anymore because it's basically full of scar tissue. And so you can have some other things that will manifest. And so then it kind of makes this disease start to look similar to other disease states. So obviously, early diagnosis and treatment is significant for these patients so that you can kind of prevent some of those other complications from happening. Now, the most common treatment for polycythemia vera is just doing those therapeutic phlebotomies to kind of try to reduce that hemoglobin concentration within those patients. You can also use things like the chelating agents, hydroxyurea, and then that's typically going to be used in your high-risk patients to kind of prevent some of those thrombosis type effects from happening. Or there's also kind of some treatments with using low-dose aspirin for the kind of the same respect. And then there are some additional treatments that are being developed to kind of inhibit that JAK2 mutation. So there are a few things out there, but typically just doing that therapeutic phlebotomy to kind of treat those symptoms is part of that treatment, along with trying to prevent those thrombotic type episodes. Prognosis: about half of the polycythemia patients will have a survival of about 15 months without treatment. It can be extended for about 14 years with just doing the therapeutic phlebotomies alone. The median survival age for patients is basically, all of this really is going to be affected based off of the patient's age, the karyotyping, the leukocytosis, the history of the patient, and whether or not they had history of thrombosis or factors that can lead to thrombosis. So all this is going to affect that survival age. And the patients are kind of categorized based off of how they present with all of these various factors to determine whether they're high risk, low risk, or medium risk based off all of this criteria. as far as the overall median survival, it can be anywhere from 10 to 20 years just based off the treatments that are currently used. Essential thrombocythemia is a clonal myeloproliferative neoplasm that has an increased megakaryopoiesis and thrombocytosis. So usually you'll have your thrombocytosis that's going to present with a platelet count greater than 600. Sometimes it can reach as high as greater than 1,000. However, the WHO criteria requires that that the patient have a sustained thrombocytosis with a platelet count of 400 or greater. Over the years, it has been also known to be called primary thrombocytosis, idiopathic thrombocytosis, and hemorrhagic thrombocythemia. Now, because there is not really a well-defined diagnostic algorithm for this, determining the true incidences of essential thrombocythemia has been very difficult to do. Based off some diagnostic systems, it has been estimated to be between 0.6 to 2.5 cases per 100,000 persons per year. And the prevalence rates have been reported to be 38 to 57 out of 100,000 people, with women being more affected than men. Most cases are seen in individuals between the age of 50 to 60, but there's also a peak incident that can happen primarily in women during the childbearing years, so this is usually around 30 years of age. Now, most of the mutations that we saw within the polycythemia area also happen with the essential thrombocythemia. 3 of these mutations in particular, the JAK2, the MPL, and the CALR, are considered as the driver mutations for essential thrombocythemia. More than half of the patients diagnosed with essential thrombocythemia are actually discovered in the laboratory unexpectedly because of elevated platelet counts on a routine CBC, while the rest of the patients may present to their physician because of some sort of vascular occlusion or hemorrhage. Now, the vascular occlusions are often the result of microvascular thrombosis within the fingers or thrombosis within the major arteries and veins that can happen in a variety of the organ systems, including the splenic and hepatic veins, as well as some other syndromes. So patients will often have repeated splenic infarctions and can result in splenic atrophy. Thrombosis can actually result in a pulmonary emboli, or in other words, a blood clot in the lung, and neurological complications like things like headache, paresthesia in the extremities, visual impairments, ringing in the ears. Arterial thrombi can cause a myocardial infarction, or in other words, a heart attack, transient ischemic attack, and cerebral vascular incidences or strokes. Bleeding can occur from the mucosal membranes in the GI tract, the skin, urinary, upper respiratory tracts. So in other words, when you start affecting those platelets, you're going to start seeing a variety of things that are going to happen because of it or as a result of it. You can also see patients will have issues with the spleen. They can present with abdominal fullness, fatigue, weight loss, night sweats, Raynaud's syndrome. That's where you see the fingertips. Their patients, their fingertips will turn blue, especially like when they get cold. Sometimes they can even go white. And patients can also present with gout. A diagnosis is going to include the fact that you're going to have to differentiate essential thrombocythemia from other secondary or reactive thrombocytosis and other myeloproliferative neoplasms. So WHO requires that 4 of the major and 1 minor diagnostic criteria for an actual diagnosis. And so that would mean that they would actually need to meet all 4 major criteria, or the first 3 of the major and 1 of the minor criteria. So the major criteria, they're listed here, which is going to include the megakaryocytic proliferation with a large immature morphology, with little to no granulation or erythroid proliferation. Rarely minor grade 1 increase in the reticulin fibers. They must not meet any criteria for the BRCA-ABL1 positive CML, polycythemia vera, or basically any of the other myeloproliferative neoplasms, and they must demonstrate the either the JAK2 V617F mutation, the CALR mutation, or the MPL mutation. The minor criteria is going to be the presence of a clonal marker or the absence of evidence of reactive thrombocytosis. Now, things that we will see in the laboratory on the peripheral blood, the main thing is going to be that you have that platelet count greater than 400. Overall, it's going to appear normal, but you will have some very giant, bizarre-looking platelets or platelet aggregates, micromegakaryocytes, and megakaryocytic fragments. You can also have your platelets that will actually present in clusters, and then they tend to accumulate near the thin edge of that smear. Other diagnostic criteria would include normal red blood cell mass, stainable iron in the bone marrow, absence of the Philadelphia chromosome, the lack of the marrow collagen fibrosis, absence of splenomegaly and leukoerythroblastic reaction, and the absence of any other known cause of reactive thrombocytosis. So basically, it's a process of ruling out everything else. Now, in the early phases of the essential thrombocythemia, your peripheral blood will actually show an increased number of those platelets with the abnormality in the size and the shape, which we kind of covered already. And then the bone marrow will have those megakaryocytes that are increased in number as well as in size. Now, the patients that actually have thrombocytosis without any kind of history of thrombosis or cardiovascular risk, they may not require any sort of treatment, but otherwise treatment is initiated just to reduce the platelet count and kind of control the thrombosis. So this is going to basically involve preventing or alleviating very early that risk for the hemorrhagic or vaso-occlusive complications that can happen when those platelets start to increase to those high numbers. Plateletpheresis can actually be used to decrease the platelet count rapidly. With plateletpheresis, basically, it's a process. Basically, what we do is we do plateletpheresis for blood donors. So we pull out the platelets and put the rest of their cells back into their body. So essentially, this can be used for patients that have essential thrombocythemia to help remove some of those platelets to reduce the amount of platelets that are circulating to hopefully help alleviate any of those complications that can arise from having the excess of platelets present in the circulating peripheral blood. There are also some different medication type treatments like the chelating agents that can help to essentially reduce that thrombocytosis and leukocytosis. If you're going to target one line, you're basically going to target both, so it's going to reduce those leukocytes as well. Prognosis for these patients is typically pretty long, provided that they don't have any kind of serious complications, but the patients that do have complications are typically going to be the ones that ultimately that's going to be their demise, is some sort of thrombolytic or hemorrhagic complication that results from it. But overall, the median survival age is about 20 years of age. Or, excuse me, not 20 years of age, but 20 years of actually living with that disease. Now, primary myelofibrosis does have some alternative names that it has been referred to in the past, so if those are used, don't let that confuse you. But again, it too is a clonal hematopoietic stem cell myeloproliferative neoplasm, in which there is splenomegaly and ineffective hematopoiesis associated with areas of the marrow, hypercellularity. So you're going to have leukocyte and erythrocytic type blast, extramedullary hematopoiesis, fibrosis, and increased megakaryocytes. It's the least common of all of the myeloproliferative neoplasms, but it is the most aggressive form. So it can actually form as a consequence of polycythemia vera and essential thrombocythemia. Now, your primary myelofibrosis, those alterations can be seen in various studies where there's actually a cytogenetic abnormality detected in the normal blasts, neutrophils, macrophages, basophils, and megakaryocytes. Now, it has been shown that female patients that are heterogeneous for glucose 6-phosphate dehydrogenase isoenzymes will have the primary myelofibrosis cells of a single enzyme isotype, whereas the tissue cells, including the marrow fibroblasts, will actually contain both enzyme isotypes. So that's not kind of something that's unique to female patients. So let's discuss a little bit about what myelofibrosis is. So fibroblasts are actually in the bone marrow, and they're responsible for producing collagen that will actually provide a little bit of structural support for those hematopoietic stem cells. Now, what happens in primary myelofibrosis is that there is some sort of reactive process that causes an overproduction of that collagen that will actually start to disrupt the normal architecture of the bone marrow, and then that kind of replaces that hemopoietic tissue that will result in a pancytopenia. So if you don't have that tissue present to produce those cells, then you're going to have a reduced amount of cells that are actually present in the bone marrow. So it's almost like it just kind of leaves behind a scar tissue type of substance, and that's what this myelofibrosis is. Now, myelofibrosis, this disease process consists of 3 of the 5 different collagens, and so it contains collagen 1, collagen 3, and collagen 4. Also, with primary myelofibrosis, you also see something called extramedullary hematopoiesis, and this is clinically recognized as being hepatomegaly or splenomegaly. And it seems to originate because there's a release of those clonal cells into circulation, and those cells will start to accumulate within the spleen, the liver, or other organs throughout the body. So this could be even down to the adrenals, kidneys, lymph nodes, bowels, breast, lung, the mediastinum, and just throughout various areas of the body. Now, the cause is unknown, but in research, it's been thought to be caused or seen some reactivity based off of chemicals, hormones, viruses, radiation, immunological factors. So they've all been kind of implicated in helping to cause this disease process. It is associated with an increased circulation of hematopoietic stem cells, but the fibroblasts are secondary abnormality, and they're not clonal. So those fibroblasts that are actually forming is not going to kind of keep reproducing to produce those cells. Once those cells are gone, they're gone. And there may actually be some B and T cell involvement. There is an increase in circulating unilineage and multilineage hematopoietic stem cells, so you could have one particular cell line or all cell lines that are circulating. And there is an increase in the CD34 cells, and it's typically going to be about 300 times greater than normal values should be. The increase in circulating CD34 cells is what actually separates the primary myelofibrosis from any of the other myeloproliferative neoplasms. So, and it also kind of helps to predict the degree of splenic involvement, which kind of helps to assess the risk of conversion to an actual acute leukemia. The pathogenic mechanism for primary myelofibrosis is due to a somatic mutation in one of the 3 driver genes. So these are the JAK2, the CALR, and the MPL genes. And what this does is actually affects the JAK-STAT pathway. Primary myelofibrosis is seen in patients that are older than the age of 60, and it's seen equally in both male and female patients. The disease can be asymptomatic, but it usually progresses as a slow chronic condition. On occasion, it can follow a rapid acute course that's marked by a very rapid fibrosis formation, and it's also associated with a pancytopenia. Now, symptoms can include symptoms can actually result from an anemia, a myeloproliferation, or splenomegaly, and it can include fatigue, weakness, shortness of breath, palpitations, loss of appetite, weight loss, night sweats, pruritus, pain in the extremity and bones, bleeding, discomforts, pain in the left upper quadrant, and that's going to be due to that enlargement of that spleen. There is a small percentage of patients that can actually go through a hemolytic type of episode during their disease progression, but you can also have a small percentage of those patients that will actually, you can see that the effect of that hemolysis kind of spill over to where you'll see the presence of it in the urine, as well as you'll see a decreased blood haptoglobin. Some patients can develop bleeding issues due to there being a combination of thrombocytopenia or abnormal platelet function. And so when you do see these types of abnormalities happen, then it does kind of suggest that the patient is more at risk for a chronic disseminated intravascular coagulation, or DIC. Primary myelofibrosis can present with a variety of changes within the laboratory test values, or you're reviewing the blood smear that can reflect both quantitative and qualitative abnormalities within that patient. Now, in the early stages, anemia, leukocytosis with a left shift, thrombocytosis can be identified, and this is very consistent with the myeloproliferative neoplasms. However, as the fibrosis starts to develop within the bone marrow, the blood cell counts will start to fall, and you will start to see a pancytopenia that will develop over time. And you'll also see that leukoerythroblastosis, anisocytosis, and poikilocytosis. So being able to examine the bone marrow biopsy specimens helps to provide more of the information that's needed for diagnosis. Now, this is because the bone marrow specimens can be a little bit difficult to obtain and can usually yield a dry type, and that's just because where that fibrosis is taking place within that bone marrow. And then you get the granulocytes and the megakaryocytes, and you get all of those increase in those cells, and of course that's going to kind of be over time, it's going to be replaced, and you're going to get that myelofibrosis within that bone marrow tissue, so that you'll get that normal population that's usually reproducing to make cells within the bone marrow is going to kind of get replaced with those fibrotic type cells, and so you're not going to get the normal cell populations that you typically would get within a bone marrow finding. A humoral response is actually altered in approximately 50% of these patients with primary myelofibrosis. So that just means that there's an immune response within the various body fluids throughout the patient's body. And what you will see is actually the appearance of autoantibodies to erythrocyte antigens, nuclear proteins, gamma globulins, phospholipids, or in other organ-specific antigens. And so these circulating immune complexes, they're increased proportions of bone marrow reactive lymphocytes and the development of amyloidosis, or evidence that there's actually an active immune response that's actually taken place. The collagen disorders that coexist with the primary myelofibrosis also suggest that the immunological process may actually stimulate that marrow fibroblast activity. Now, just like most of these myeloproliferative disorders, there are a variety of approaches that can be used for treatment. One of the ones that kind of stands out is those JAK inhibitors that will actually improve the splenomegaly, and it helps with those symptoms in those patients, the primary myelofibrosis patients, more than it actually does with the essential thrombocytopenia and the polycythemia vera. Prognosis for these patients, there's an average survival rate from the time of diagnosis for about 5 years, but there have been patients that have lived as long as 15 years. And the mortality within these patients is usually associated with infection, hemorrhage, post-splenectomy complications, cardiac failure, and the fact that this disease can progress to an acute leukemia. Some of the other myeloproliferative neoplasms that I just want you aware of, you don't really have to know a lot of detail about them, are going to include the chronic neutrophilic leukemia. So this is a clonal disorder in which there is a hyperproliferation of the neutrophilic cells in the bone marrow that produces sustained neurophilia in the peripheral blood and hepatosplenomegaly. So you're going to see a really high increase in that actual neutrophil count. With chronic eosinophilic leukemia, not otherwise specified, this too is a clonal proliferation of the eosinophils from the eosinophil precursors that dominate in the bone marrow and peripheral blood. So you can also see the eosinophils in other peripheral tissues like the heart, lungs, central nervous system, gastrointestinal tract, skin. Now, the myeloid lymphoid neoplasms with eosinophilia and rearrangement of the PDGFRA, PDGFRB, or the PGFR1 or the PCM1, JAK2 were segregated into their own category, and there were 3 reasons why this was done, and that's because each disorder has an underlying neoplasm of either the myeloid or the lymphoid type. These conditions usually have an associated eosinophilia, and these mutations result in a constructive activation of a tyrosine kinase and respond to tyrosine kinase inhibitors like the some of the certain drugs, the imatinib and the ponatinib. Not sure if I'm pronouncing those medications correctly. The mastocytosis is no longer considered a myeloproliferative neoplasm, and it has actually been further subdivided into 3 categories, with cutaneous mastocytosis, systemic mastocytosis, and localized mast cell tumors. Now, the category myeloproliferative neoplasms unclassified is designed to capture disorders that express myeloproliferative features, but they don't really fall into any of the specific categories or meet the criteria for the specific conditions, or they have features that overlap multiple specific conditions. So it's just kind of lumped together into one sum because it's probably not well understood at this point, or just the technologies hasn't been developed yet to really clearly understand those disease processes.